Today's lecture is entitled The Cranial Nerves and the Autonomic Ganglia in the Head. My name is Carlos Andres Suarez-Quian. I am the author of this lecture and will narrate it for you. Much of the material I will present to you in this lecture is taken from a book I co-author with my colleagues, Joel Valensky and Wendy Robertson. The title of the book is The Clinical Anatomy of the Cranial Nerves, the nerves of old Olympus towering top. You will see in a moment why we chose this title. To begin the lecture, I paraphrase Gertrude Stein. A cranial nerve is a nerve is a nerve. And as much as I admire Miss Stein, she missed the boat on this one. The cranial nerves are magical. These nerves play an essential role in the processes that allow you to experience the wonder of the world around you. That is, to experience smell, taste, sight, and hearing, to maintain your balance and also to feel the wind on your face, a kiss on your lips, and to express feelings using the muscles of your face without ever being consciously aware that you're doing so. Similarly, speaking, singing, good or bad, and eating are all directly controlled by the cranial nerves. In fact, one cranial nerve, the 10th nerve, or vagus, is responsible for controlling digestion from your lips to almost the end of your digestive tract, and this same nerve regulates heart rate, breathing, and speech. In contrast, the nerves of the rest of your body, the spinal nerves, primarily control voluntary muscle movement and convey simple sensations, for example, touch, but do not have the finesse of the cranial nerves. In other words, we think the spinal nerves are rather mundane and cranial nerves are, well, as we said at the beginning, magical. But I still recommend a rose is a rose is a rose to you. Let's now superimpose a dissection of the cranial nerves as they emerge from the base of the brain on a netter drawing of where the cranial nerves travel to and exert a function at their final destinations. And at this point, let's list the 12 cranial nerves. You will need to learn them and be able to recall what they do for the rest of your careers, so I urge you to spend some time with them. But don't worry, there are mnemonics to help you memorize the names of the nerves. And here's the most well-known mnemonic for the names of the cranial nerves, and the reason we name our book as such, On Old Olympus towering top of Finnen German viewed zum Hops. The beginning of each word corresponds to the first letter of the corresponding nerve. If you have a grandfather or grandmother who graduated medical school in the 1950s, I'm sure they will know this mnemonic. I did try and find out who first came up with it, however, but was unable to find out. I'm also providing a different version from the 1980s, and I've read where the Harry Potter generation has come up with their own mnemonic. It is up to you to decide how you'll remember the names of the cranial nerves, but you must learn them because you will need to apply them in clinical medicine. And now, I come to the objectives of this lecture. Here, I list 3 features that you must know for each cranial nerve. First, you must know what is the function of the specific cranial nerve. Second, if you suspect that your patient is suffering a cranial nerve lesion, you must be able to test the function of the cranial nerve. And third, you must know what are the major foramina involved in the cranial nerves and their branches. This latter may provide a clue as to the possible site of the presence of a tumor or an infection. And I cannot stress enough, think function when you think about the cranial nerves. Let's start with the first cranial nerve, the olfactory nerve. What do we do with this nerve? We smell. The actual nerves that detect the smell are located at the roof of the nasal cavity. It is precisely why you're asked to stick your nose inside a wine glass prior to drinking it to discern its bouquet, or nose, as it is said in the industry. If the odoriferous molecules do not reach this olfactory epithelium, you will not be able to smell the wine. The olfactory cells then traverse through the cribriform plate of the ethmoid bone to end at the olfactory bulb. Hence, there is a direct connection between the olfactory epithelium and the anterior cranial fossa, and this has clinical implications. Trauma to the region can result in tearing of the cranial nerve, resulting in anosmia, the loss of smell, and even more seriously, cerebral spinal fluid rhinorrhea. Examine the drawing to clearly visualize the pathway of how the olfactory nerves reach the olfactory bulb. The cribriform plate is part of the ethmoid bone that is indicated in the image. Cribriform means sieve in Latin and is where the olfactory bulb sits. Hence, you can think of the olfactory nerves as microscopic structures percolating through the holes of the cribriform plate to reach the olfactory epithelium. And by the way, ethmoid also means sieve in Latin. Using our three-part scheme of what we need to know about each cranial nerve, we now know what the olfactory nerve does, what are the major foramina involved, and now we need to discuss how we test for its function. And here it is. We simply ask patients to see if they can smell common everyday objects. Loss of smell has many causes and may even be congenital. Before leaving the topic of smell, you may have heard that one of the early symptoms exhibited by COVID-19 patients is anosmia, or partial loss of the sense of smell, often accompanied by changes in taste. In a recent study published by the Journal of Neuroradiology, the virus appears to damage the olfactory bulbs by causing microbleeding in this area. Shown in this image is what microbleeding will look like in the area of the olfactory bulb when examined using MR imaging. We now move to cranial nerve 2, the optic nerve. Some anatomical details are described here in the text. What do we do with this nerve? We see. Need I say more as to its importance? Imagine your life now without vision. Will you be here at medical school? In reality, the optic nerve is not a true cranial nerve. It is an outpocketing of the central nervous system. But eliminating it now from the list of cranial nerves would ruin the mnemonic. You will spend more time studying the visual pathway in neuroscience. Here, let's just describe the basic pathway of how we see. I have drawn an axial section of the head at the level of the optic nerve. Let me put in some labels for orientation. The retina is found at the back of the eyeball and initially collects the information we see. The information then travels by way of the optic nerve, cranial nerve 2. With respect to the information we gain via our eyes, it will cross over at the optic chiasm. That is, the right eye will send information to the left side of the brain and vice versa. The visual information leaving the optic chiasm will then enter an optic tract and will ultimately end up at the visual cortices of the occipital lobes. Now, let's be a little bit more specific and follow a ray of light that enters our retina that has arrived there from our temporal field of vision. Here it is from the left eye. Note how it strikes the medial aspect of the retina, travels to the optic nerve, then crosses over to the contralateral optic tract. And here it is from the right eye. It follows a similar path, but to the opposite side. Now let's see what happens when a ray of light strikes the lateral retina on the left eye and the right eye. The light rays that strike the lateral retina does not cross over via the optic chiasma. Why does crossing over occur? Apparently, crossing over is required for binocular vision and allows for depth of field. The temporal side fibers are uncrossed and the fibers from the right half of both retinas form the right optic tract. Fibers from the left half of both retinas form the left optic tracts. You'll learn much more about the visual fields in neuroscience. For now, understand that the visual fields are complicated. Testing of the nerve, of course, is straightforward. Can you see? But it turns out there's more to it than that. Let's just look at a quick example of how we test vision to appreciate that it can be quite complicated. When you shine a light into someone's pupil, the pupil contracts on the ipsilateral eye. But at the same time, the pupil of the contralateral eye contracts also, albeit not as completely. This is described as both pupils demonstrating concentric contraction and is the expected outcome of shining the light into one eye. Based on the previous discussion of how light rays cross over from one visual field to the other at the optic chiasma, that perhaps the afferent light pathway, that is the light shining on the ipsilateral eye, and the efferent pathway eliciting the pupillary contraction for the contralateral eye, may originate within the chiasma. But the pathway is far more complicated and involves the midbrain as well, as shown in this image. The details of these pathways will be featured in neuroscience. For now, just be aware that the pathways are complicated and you'll be expected to know them, but in a different course. Aside from the optic nerve that allows us to see, we also need to consider cranial nerves 3, 4, and 6, which are responsible for eye muscles. That is, these nerves move the eyeball in the direction we wish to see. Cranial nerve 3, the oculomotor, controls all extraocular muscles except the superior oblique and the lateral rectus. Cranial nerve 4, the trochlear, supplies the superior oblique. It is called the trochlear because the intertendon of the muscle passes through a connective tissue pulley, and pulley in Latin is the trochlea. Cranial nerve 6, the abducens, supplies the lateral rectus muscle, which abducts the eyeball, hence its name. And you remember these details by the mnemonic LR6, SO4, all others by 3. Finally, all these nerves will exit the skull via the superior orbital fissure. Here's a dissection image of the 3 nerves after they've entered the orbit. And here's the location of the superior orbital fissure. It is present within the sphenoid bone, shown here in yellow. Let's now say a few words about the specific nerves that work on the eye muscles and start with the oculomotor. In the upper image, I'm showing you a dissection of the nerve, and in the bottom image, I show you a drawing representing the nerve. The nerve is motor to 4 of 6 extraocular muscles listed here. And what is also interesting, that the nerve is responsible for proprioception to these muscles. Hence, we are able to tell where our eyes are looking because of the sensory fibers present in the oculomotor nerve. This nerve is also responsible for parasympathetic innervation of the ciliary ganglion, now indicated in the dissection. And the nerve is also responsible for the motor component for the lens accommodation reflex, which changes the shape of the eye so we can see up close. The efferent pathway is by the optic nerve, whereas the efferent pathway is by the oculomotor nerve. The nerve will activate ciliary muscles inside the eye to alter the focal distance of the eye. Lesions of the nerve are easily recognized by the condition of ptosis, or drooping of the upper eyelid, and mydriasis, or dilation of the pupil of the eye. Also, since the pupil cannot be adducted, it tends to be abducted by the unopposed action of the lateral rectus, a muscle that abducts the eyeball. And of course, since the lens cannot be accommodated, vision will be impaired. We next focus on the trochlear nerve, which innervates only one muscle, the superior oblique. This is the most difficult nerve to preserve in an orbit dissection. The nerve has a long intracranial path to reach the muscle and is readily torn during severe head injuries. Since the muscle action is to depress and abduct the eyeball, if the nerve is damaged, the affected eye will not be able to direct inferolaterally and result in diplopia, or double vision, when looking downwards. I include more details in the slide if you wish to stop the movie and read it now. The third nerve in this group, the abducens, is now labeled in the image. The nerve provides motor innervation to the lateral rectus. The nerve can also be torn by severe head injuries and thrombosis in the cavernous sinus. When this nerve is damaged, diplopia will be present in all directions except when gazing to the side opposite to the lesion. As you will learn when we do the cranial vault lab, the cavernous sinus is an area in the middle cranial fossa to which several venous channels drain. It is found within the dura mater, the tough covering of the brain. Here, we see the location of the cavernous sinus in the middle cranial fossa, and the appearance of the sinus in a coronal section. Now, observe the various structures that are at risk of injuring within the cavernous sinus, including the internal carotid artery. The relationship of the cavernous sinus to the various nerves is more than theoretical, although the nerves traveling through the cavernous sinus are difficult to see in a dissection. We had skipped the trigeminal nerve, but now we discuss it. It is the largest cranial nerve. It is a significant sensory nerve of the greater part of the face, scalp, teeth, tongue, and oral and nasal cavities, and it is also motor to the muscles of mastication, the digastric muscle, the mylohyoid, tensor veli palatini, and the tensor tympani. The nerve has three divisions: the ophthalmic, the maxillary, and the mandibular divisions. And note that each division can be described by a specific name, for example, the ophthalmic division, or by denoting it as a branch of the trigeminal nerve, V, with the subscript of 1. Each division will exit the cranial vault by 3 distinct routes, now indicated in the image. And the 3 divisions ultimately exit the bony skull to provide sensory innervation to 3 pie-shaped wedges of the frontal bone, the maxilla, and the mandible, respectively, indicated in the slide. The mandibular division will also innervate 4 muscles, collectively known as the muscles of mastication. We will mention a little more about them in a separate lecture. Clinical testing of the sensory component is straightforward. The patient is asked to close their eyes, and a soft brush is used to test if they can sense the brush as it gently touches the 3 distinct areas served by the trigeminal divisions, as shown in the slide. The ophthalmic division is also responsible for the sensory component of the corneal reflex. If you touch our corneas, our eyelids blink. The efferent component is via the ophthalmic division. The efferent component of the reflex is formed by cranial nerve 7. The corneal reflex components are now indicated in the slide. The corneal reflex is not the pupillary reflex. Realize that these reflexes are important to be able to discern in a patient to potentially distinguish between lesions of their cranial nerves. Trigeminal nerve injuries can result from trauma, tumors, aneurysms, and meningeal infections. They manifest in the loss of ability to appreciate soft tactile, thermal, or painful sensation on the face. A most debilitating illness associated with this nerve is known as trigeminal neuralgia, or tic douloureux. The illness affects the sensory root of cranial nerve 5 and are characterized by excruciating pain of the areas covered by this nerve. Pain was so severe that some patients would even commit suicide. A virus that afflicts individuals and manifests itself in trigeminal specific fashion is herpes zoster, commonly known as shingles. The virus typically remains latent in the sensory neurons of the trigeminal ganglion. With an eruption along V1, the concern is for the cornea. Finally, we cannot forget that the motor component of the trigeminal nerve can also be injured, generally as a result of trauma, tumors, aneurysms, or even meningeal infections. The injury may result in paralysis of the muscles of mastication, and the deviation of the mandible will occur towards the side of the lesion, and somewhat downwards, giving that the muscles of mastication cannot hold up the mandible. We'll discuss this further in a later lecture. The next nerve up is cranial nerve 7, the facial nerve, and it is quite a remarkable nerve, perhaps my favorite. The motor root is motor to the muscles of the face and the scalp, including the platysma, stapedius, stylohyoid, and the digastric, specifically the posterior belly. I know this does not mean much to you now, but it will as we continue the head and neck module. Sensory roots provide taste fibers for the anterior 2/3 of the tongue by way of the chorda tympani nerve and the soft palate. If you love chocolate, the chorda tympani is your friend. The nerve carries parasympathetic fibers to the lacrimal, submandibular, and sublingual gland, and glands of nasal and palatine mucosa. That is, the nerve helps with salivation, but also to express our emotions of both joy and sadness. And finally, the nerve enters the internal acoustic meatus and exits the skull by way of the stylomastoid foramen. First, let's see where the facial nerve leaves the base of the brain and enters the skull. And here it is, at the internal acoustic meatus, along with cranial nerve 8. Don't expect to be able to identify the nerve here, except if you have a view of all cranial nerves. At most, you can tell where the internal acoustic meatus is located. As to where you find this meatus, it is on the medial aspect of the petrous part of the temporal bone. You need to know this when you're removing the brain from the cadaver, and because the tentorium cerebelli attaches to the petrous part of the temporal bone. For your convenience, I colorize the temporal bone in pink. I have now labeled the squamous part of the temporal bone. Put your fingers just above the ears. You're now at the corresponding location of the skull that is labeled as the squamous part of the temporal bone. After showing you where the facial nerve enters the skull, let me show you now where it exits the skull. On the left, I show you a lateral view of the skull, and in the middle image, I show you the base of the skull. This view is magnified on the right-hand image. Let's label some landmarks. For example, the stylus process and the mastoid process. Go behind your ear and feel the hard bump. This is the mastoid process. Please do not try to feel the stylus process. This would hurt. The mastoid process develops after we are born by the continuous pull of the sternocleidomastoid on it as we develop the ability to raise our heads. Think of it as the protector of the facial nerve. Now look at the foramen just medial to the mastoid process, the stylomastoid foramen. It is here that the facial nerve exits the skull. Remember, it traverses the petrous part of the temporal bone, and now it is outside the skull. And now think why an infection of the mastoid process may be deleterious to the facial nerve. There are sinuses within the mastoid process, and these can become infected from such procedures as inserting a non-sterile trocar to pierce the pinna of the ear. Mastoid sinus infections are notoriously difficult to treat and may require debridement of the infection with insidious consequences for the facial nerve. And we will actually look for the stylomastoid foramen just deep to the large salivary gland, the parotid gland as shown in this image, when we look for the facial nerve when it exits the skull. What does this nerve do? It sends branches to the muscles of facial expression, all of them, no exceptions. You want to show emotions? You need this nerve. You want to close your eyes? You need this nerve. You want to keep from drooling? You need this nerve. We will go into detail later how these muscles all work on your face to control these activities. But in addition to the motor components to the muscles of facial expression, a small branch from the nerve, the chorda tympani, exits the nerve and joins up with a branch of the trigeminal nerve, the lingual nerve, and then proceeds to the anterior two-thirds of the tongue to gather the sensation of taste. I just love this branch. Now you know where this nerve exits the skull, what it does. What else do you need to know about it? How do you test for it? And it's very straightforward. You ask your patient to make faces as shown in the slide, and also test for taste on the anterior two-thirds of the tongue. However, a word of warning. Please do not put grits on a northerner and ask them what they taste, or put boiled tasteless potatoes on a southerner and ask them what they taste. You need to be aware of what people are used to eating if you plan to assess their taste buds. Me, I know very well the curly mint you need for the Cuban mojito versus the peppermint of the mint julep. Let's just say I've had very nice culinary experiences in my life. Let's now mention Bell palsy, an affliction of cranial nerve 7, and mention how you would discern such an affliction. Imagine a virus that damages your cranial nerve 7. How would your face look if now the muscles of facial expression on one side of your face become totally flaccid? Can you tell in this person which side of the face is suffering from Bell palsy? Were you correct? His right side of the face was afflicted. Stop the video and read the text for more information regarding Bell palsy. And specifically, think back to the corneal reflex and understand why Bell palsy can be quite deleterious to the well-being of a healthy individual. If you lose your ability to blink, a result of Bell palsy, you lose the ability to keep your cornea moist, and it can become dry and brittle and lead to infections and even loss of the cornea. Indeed, one of the major complications of Bell palsy is losing the corneal reflex. We now move to cranial nerve 8, the vestibulocochlear nerve. I will not spend much time on this nerve, except to say that we should consider it as two separate nerves functionally, but anatomically it is described as a single nerve. We use this nerve to both maintain balance and to hear, rock and roll of course, and definitely classical music. But why would anyone want to damage their ears with country music is beyond me. Losing one's hearing, however, has been considered a major disadvantage historically, and for years it was not possible to determine if the hearing loss was permanent or transient. There's a simple test that one can do using a tuning fork to discern whether hearing loss is likely to be permanent or amenable to treatment. If a vibrating tuning fork is placed near the ear and the patient cannot detect sound, they are considered deaf. However, this test cannot determine how egregious the loss of hearing is. By placing a vibrating tuning fork on the mastoid process of a deaf individual, however, and asking them if they sense sensation, as shown on the left panel, will allow the clinician to determine if hearing loss is due to sensorineural loss, that is, loss of the nerve, or if the deafness can be due to less egregious causes. If the nerve is present, a vibrating tuning fork should elicit stimulation of the sensory cortex and raise hope for hearing recovery. We now move to cranial nerves 9, 10, and 11, the glossopharyngeal, the vagus, and the spinal accessory. And these nerves gave Galen a bit of a difficult time. He thought they were all a single nerve. The three nerves exit the skull via the jugular foramen, so that answers one objective for each of the three nerves. What do they do? Well, this gets a bit complicated. Looking at the glossopharyngeal nerve, this nerve is sensory, motor, and provides parasympathetic innervation to the parotid gland. We will spend specific time on this nerve later in the lecture. So for now, let's just remember that the glossopharyngeal nerve is a mixed nerve that has both motor and sensory functions. Let's look more specifically at the glossopharyngeal nerve. After the nerve exits the jugular foramen, it sends out several branches. One is a carotid branch to the carotid sinus in the carotid body. These are considered visceral sensory branches and are responsible for detecting blood pressure and oxygen tension, respectively. And a much larger branch, one known as a pharyngeal branch. In addition, after exiting the jugular foramen, the glossopharyngeal nerve will send a branch back into the mastoid process, the tympanic nerve. And this nerve will ultimately connect to the plexus and emerge as the lesser petrosal nerve that will provide parasympathetic innervation by way of the autonomic ganglion to the parotid gland. Don't worry about these details at this time. We will review this pathway again several times during the course. In this second drawing of the glossopharyngeal nerve, we can actually see the pathway by which the parotid gland is innervated. We will discuss this pathway in more detail later in the lecture and again in other lectures. What I want you to focus now is on the pharyngeal branch. This branch will be motor to one muscle, the stylopharyngeus, and the pharyngeal constrictors, as well as send branches to the posterior one-third of the tongue. These branches will be responsible for both taste and general sensation. Overall, a lot of details, but bear with me. We will review these concepts again and again during the module. I will tell you, however, that it is very easy to test whether this nerve is functional, simply by checking for the gag reflex. If you touch the anterior aspect of the tongue, it is unlikely that your patient will gag. If you touch the posterior one-third of the tongue, however, and cranial nerve 9 is functioning, your patient will gag. I will mention, though, that this nerve is rarely injured, except in individuals who exhibit an exceptionally long stylus process. In A, an X-ray image of an individual with exceptionally long styloid processes is shown, and on the right, the patient is shown mid-procedure during the styloidectomy. In these individuals, the stylus process can be damaged due to trauma, and because the glossopharyngeal nerve is near the stylus process, the different functions controlled by this nerve will be impaired. This is a very rare condition, difficult to diagnose, and yet when it is, people immediately realize that if they had simply remembered their basic anatomy, the impacted symptoms would have readily led to the cause. Next, we describe the vagus nerve, the most complicated of all cranial nerves. It helps control the digestive tract basically from its origin to almost its termination, and in between, it controls our vocal cords, heart rate, respiration, and digestion. Let's just say we can spend a lifetime studying this nerve and perhaps not reach a full understanding of all that it does. But what do we know about this nerve, and what does it do in the head and neck? Let me summarize a few points of interest using this drawing. It emerges from the jugular foramen and descends within the carotid sheath, behind and between the internal jugular vein and the internal common carotid arteries. From superior to inferior, its branches are as follows. The auricular. This nerve enters the mastoid on its lateral wall of the jugular foramen. The auricular provides general sensory to the auricle, the external acoustic meatus, and the tympanic membrane. Do you want to know why some people experience taste when they hear music? This is the nerve that does that. The next branch is the pharyngeal. This branch contributes to the pharyngeal plexus and provides motor innervation to muscles of the pharynx and palate, specifically to the levator veli palatini. It is the reason you're asked to say ah when you visit the doctor. The superior laryngeal nerve is the next branch. It descends lateral to the pharynx and then divides into the internal laryngeal and the external laryngeal nerves. Posterior superior to the tip of the greater horn of the hyoid, medial to the external carotid artery. The internal laryngeal nerve penetrates the thyroid membrane and provides general sensory innervation to the mucosa of the larynx and pharynx, and general sensory and taste innervation to the very posterior part of the tongue and epiglottis. This is the nerve that's stimulated when you feel like coughing. The external laryngeal nerve is motor to one muscle, the cricothyroid muscle, the muscle that allows you to sing falsetto if you can. Finally, we get to the recurrent laryngeal nerves. The right and left recurrent laryngeal nerves loop posteriorly around the right subclavian artery and aortic arch, respectively. They ascend in the grooves between the trachea and esophagus on their respective sides. As they ascend posterior to the lobe of the thyroid gland, they enter the larynx and provide general sensory innervation to the mucosa of the larynx and the pharynx, and motor innervation to all the muscles of the larynx except the cricothyroid. I told you the vagus is complicated, and this is just in the head and neck. The motor component of the vagus, however, gives us a way of how to test for its functionality. You will learn that the uvula is elevated by a muscle, the levator veli palatini, that is innervated by the vagus nerve. When you ask your patient to say ah, if the vagus component is damaged, the uvula will deviate away from the afflicted side. I will mention, however, that the vagus controls so many bodily functions that if it is damaged, movement of the uvula is the least likely of afflictions to be experienced by your patient. They're likely in ICU, and you have many other worries to think about. However, I did find an image of a deviated uvula in the literature, and I show it to you now. I spent nearly 30 years of my academic life and had never seen a deviated uvula until someone posted this image on the web. What about cranial nerve 11? It is a motor nerve to the sternocleidomastoid and to the trapezius muscle. We will see this nerve when we dissect the posterior triangle of the neck. And here's an image from our book on the cranial nerves, describing the old concept of cranial nerve 11 and its association with the vagus, versus the current interpretation of this relationship. Previously, it was thought that cranial nerve 11 joined the vagus nerve. Current thinking is that it does not. Stop the video if you wish to look at the details. But the bottom line, Given that the nerve goes to the sternocleidomastoid and the trapezius muscles, testing for this nerve is straightforward. Ask your patients to shrug their shoulder against pressure. Have you forgotten the action of the trapezius already? Remember, it is the only muscle that acts on the upper limb that is not innervated by the brachial plexus. We have now arrived at the last cranial nerve, the hypoglossal. Why do we call it by this name? Because glossus means tongue in Latin, and this is the nerve that is below the tongue and innervates all the muscles of the tongue except one, the palatoglossal muscle. We will spend more time describing the tongue in a separate lecture. But one feature of the hypoglossal nerve that I should mention now is that the nerve fibers that regulate the strap muscles of the neck, required for swallowing, piggyback onto the hypoglossal nerve. Again, we'll present more details about this relationship in a later lecture. But now, how do you test for this nerve? You ask your patient to protrude their tongue, and if the nerve is afflicted, the tongue will deviate to the afflicted side. We'll describe in a later lecture why this is so. But also, the tongue has intrinsic muscles regulated as well by the hypoglossal nerve. If the nerve is damaged, the tongue can show the characteristic pattern exhibited in the inset picture. I now finish the lecture by briefly discussing the four autonomic ganglia found in the head. They include the ciliary ganglion, the pterygopalatine ganglion, the submandibular ganglion, and the otic ganglion. What nerve modality will be reaching these autonomic ganglia? The answer is here in the box. Each ganglia will receive somatic sensory and visceral motor innervation in the form of parasympathetic innervation. In addition, each ganglia will be associated with sympathetic innervation, although not precisely as shown in the image. The sympathetic nerve will not specifically travel through the ganglia as indicated in the drawing. Let's now focus more on the autonomic ganglia and trace the nerves that serve them. We look at the somatic sensory nerves that serve the ganglia, indicated by the black line in the image, and note that each ganglion is served by a distinct branch of the trigeminal nerve. V1 does the ciliary ganglion, V2 does the pterygopalatine ganglion, and V3 does the submandibular and otic ganglia. Again, these are simply somatic sensory nerves, and they course right through the ganglia and come out the other side. We now examine the parasympathetic contributions to each ganglia by following the red line. The ciliary gland is served by the oculomotor nerve. The pterygopalatine gland is served by the facial nerve, as is the submandibular gland. And the glossopharyngeal nerve does the otic gland. I want to emphasize that these four parasympathetic branches serving the autonomic ganglia are preganglionic. They will synapse at their respective ganglia, then exit along with a corresponding sensory nerve as postganglionic nerves. We now finish our discussion of the autonomic ganglia by examining the sympathetic innervation indicated by the blue lines in the drawing. And the first thing we note is that all the sympathetic innervation reaching the autonomic ganglia is postganglionic, arising from the superior cervical ganglion. These postganglionic fibers piggyback onto the external and internal carotid arteries and travel to their respective autonomic ganglia. Again, in contrast to the parasympathetic fibers serving these ganglia, the sympathetic fibers are all postganglionic. Where were the preganglionic fibers coming from? from the sympathetic trunk into the thorax. I should mention that some of these parasympathetic and sympathetic fibers have individual names. The preganglionic fibers from the facial nerve to the pterygopalatine ganglion are called the greater petrosal nerve. It will be joined by the sympathetic fibers known as the deep petrosal nerve, and together they have been given the name of the nerve of the pterygoid canal or the Vidian nerve. The parasympathetic nerve to the otic ganglion is also known as the lesser petrosal nerve. A summary of the autonomic innervation is not presented in this final slide. GS refers to general sensory nerves from the trigeminal. This now concludes this introductory lecture on the cranial nerves and the autonomic ganglia in the head.